Ladies and gentlemen, welcome back to our international ground rounds. Today's talk will be focused on something which is a daily routine. It could be an emergency, and there's something we should keep in mind. I'm very glad to have a guest today. Good morning, Luciana Tanno.
Good morning, Puya. Thank you very much again for the invitation.
So, Luciana and I today will have a discussion not only on what's important regarding anaphylaxis, but also some details in regards to a new journal that has been publishing articles since the last year, which Luciana is the chief editor. The journal is called JAHD, JAHD, and we will go throughout this at the end of her talk. But for now, please, Luciana, start to screen and share your presentation. And I remind all the attendees that the question could be typed directly from your platform. We will go through the question at the end of her talk. Today's talk is focused on unraveling determinants of severe anaphylaxis. Please, Luciana, go ahead with your presentation.
Thank you very much again, Puya, for the kind invitation. Good morning, good afternoon, good evening, everybody. It's a very great pleasure to be with you today to talk about the determinants of severe anaphylaxis. You may know that I have been working in the field for a long time, and I would like to invite you before starting to go through our table of contents of this presentation, because in fact these are questions that are required to publish in our new journal. So first, what is already known in the field? What is the new knowledge that this work can bring, and how it can impact in clinical practice and guidelines. So let's start with the first question. We know that allergic and hypersensitive conditions are very broad. They can be linked to specific systems, such as, for example, allergic rhinitis that is seen by Puya and our ENT colleagues, but it can be very complex, such as anaphylaxis, drug, food, and insect hypersensitivity, in which we can have the manifestations in different organs and different systems at the same time, or in a progression. So the data from the European Academy that has been updated recently, there is an expectation that the half of the European community will be allergic up to 2050. It means that there is a huge impact in terms of quality of life of patients and economic burden. And those that are allergic know very well how annoying it is to be allergic. But the most concerning detail of allergic and hypersensitive conditions are those that are really severe, such as anaphylaxis, that accounts about 8% of all allergic and hypersensitive conditions. So let's go through anaphylaxis. We know that anaphylaxis has been defined by many academies so far as a very severe life-threatening condition that can affect many systems at the same time and can evolve very, very quick. So in common of all these definitions, we have the severity. It's indeed a serious condition that can implicate in the risk of death to our patients, and should be recognized promptly and treated immediately. And I know that in our audience here, we are not having only allergies. And in fact, something that is really important is that anaphylaxis is not first seen by allergists. Mostly they are seen by emergency doctors, GPs, and pediatricians. And then the patients are referred in a second time to us in order to the risk stratification and investigation of etiology and specific treatment such as allergy and immunotherapy if it's indicated. So, anaphylaxis, in summary, is a killing hypersensitivity conditions in which we have different causes. The main causes for adults we know that are drugs and insect venom, and for children are foods. But we have, of course, different aspects and different etiologies for anaphylaxis that are not so frequent and should be detailed in order to advise our patients correctly, right? So I brought this publication for my co-chair of the WOW Anaphylaxis Committee, Paul Turner, in which he evaluated the data published regarding anaphylaxis admissions and fatalities. So what is known is that the number of hospitalizations due to anaphylaxis is increasing worldwide, as you can see in this first column, regardless to the etiology, but the fatalities are somehow stable. Remembering that all these data are based on official statistics, it means that at the end, we have data that are mostly severe because anaphylaxis can virtually happen in any setting. So those that are addressed to the hospital are those that are more severe, of course. And what we know is that this data may probably will change with the implementation of the International Classification of Diseases 11th version that is under implementation worldwide. So this is the epidemiological data, but something that is the aim of this article is understand the potential risk factors related to anaphylaxis. Regarding anaphylaxis, we know some risk factors that are related, but we have no idea about the combination of the risk factors, and it's something that we should understand correctly in order to propose prevention strategies to our patients and try to reduce the rate of hospitalizations and reduce the possibility of avoidable deaths. So when we are talking about risk factors, they are mostly related to the risk of new episodes. In other words, new exposure to the trigger. And we are talking about the increase of risk of death. So regarding what is known, we have exogenous and endogenous risk factors that are somehow known. But what we think it is important to understand better is that when we have some cofactors in a patient who develop a mild reaction, it can in fact imply in the mechanism, underlying mechanism, and then increase the risk for a severe anaphylaxis. Then it can probably define the phenotypes of a risk of developing severe anaphylaxis. And based on that, we can stratify the risk and try to implement prevention strategies to avoid these severe cases. Okay, so let's move forward in our publications. For this, in fact, what happened is that we decided first to, in order to reply our three questions, first understand our populations, understand the trends, and which are the populations at risk, we decided to perform evaluation of the French national database, in which we evaluate 9 years of hospitalization. So we extracted the data related to anaphylaxis based on the ICD-10 version that is ongoing in France now. The ICD is the International Classification of Diseases, and we selected the codes related to anaphylaxis as the immediate cause of admissions, but we also evaluated secondary data in order to understand what was going related to the comorbidities of patients. So, and then we categorize these patients in non-severe reactions. So the patients who had mild reactions. Severe reactions were those that had criteria of hospitalization in ICU units, for example, and fatal anaphylaxis that were those that evolved to fatal anaphylaxis during the hospitalization or at the end of their hospitalization. Here, I'm not evaluating anaphylaxis deaths data. I'm talking about those that evolve to death during the hospitalization, correct? And then with that, we were able to analyze more than 8,000 hospitalizations due to anaphylaxis, in which more than 5% were severe and almost 1% evolved to death. Most of the cases were related to unspecified cases, as usual, because the cases that are labeled as unspecified are those that we do not have the etiology or are not classified or coded correctly. However, what we can see when we evaluate the severity is that most of cases that are severe are related to drugs. So, in other words, we probably are the responsible for some of these anaphylaxis, is idiopathic anaphylaxis, followed by insect venom, and then by food. So let's move forward in order to see more details of this population. When we look for all this population that have been classified in non-severe, severe, and deaths, we see that related to the gender, they are quite similar, equivalent between male and female. However, when we evaluate the age trends, we see that the severe cases are mostly in adults and elderly population, and the deaths are mostly in the elderly population. What is expected probably because of the number of comorbidities of this population. In a similar way, we evaluated the recurrences or the number of hospitalizations due to the same cause. And we see that in severe cases and patients who evolved to death, we had higher number of recurrences, and therefore we have a higher number of expenditure due to hospitalization. Regarding the trends of hospitalization, when we evaluate over the years, we have an increasing number of hospitalization in all three groups. And when we evaluate the numbers of hospitalizations in the non-severe, what is something interesting are those that are unspecified. So far so good. It means that those patients who had not a diagnosis before evolve in a non-severe way. But what is something that is remarkable is the implication of drugs in all severe cases of anaphylaxis over time and in death as well. So it's something that we should try to think about, because most of the prescription of medications are from our side. And it's really, really important to highlight the need of not from just from allergists, but from our colleagues to have a very good clinical history related to drug allergies previously, the prescription of medications. And then what we can see here are the number of foods related to the hospitalization in severe cases of the last years. So when we see the data related to etiology and distribution per month per year, we can see that somehow drugs, we have a kind of increase in the first and last months of the year. That probably may be related that people are more ill and take more medications in the period of winter. But what is remarkable is the trend we see regarding insect venom induced anaphylaxis. That is during the period of May and September, in which we have higher temperatures and people go for holidays. So in summary, what we observed as significant was that we had an increase of insect venom hypersensitivity during this period. Probably we may have these trends in the opposite way when we have the other hemisphere. And probably something that we have to think about, but we have any clue, is the impact of climate change in this kind of pattern. So we have to observe this in the forthcoming years in order to see if it will change or not. So what we did in terms of understanding the risk factors is promoting analysis based on cluster. So we evaluated all the risk factors related to the gender, age, etiology, and comorbidities that were not only atopic comorbidities, but non-atopic comorbidities that were significantly associated with anaphylaxis. And what was really interesting is that we arrived in three main clusters. One that was mild, moderate, and severe. That was really, really interesting. So when we see these in details here, we can observe that the first cluster that was related to the mild cases of anaphylaxis, we had a prevalence of female gender with middle age, not a lot of comorbidities, but as I mentioned before, mostly were related to unspecified cases of anaphylaxis. So it means that the patients are not addressed correctly, probably to the specialists in order to have the correct diagnosis of anaphylaxis. In moderate cases, we have more male, different from the mild reactions, more aged, more than 60 years, and most of cases were related to unspecified or food-induced anaphylaxis, and the comorbidities were related to personal history of allergy and or angioedema. But here, I would like to highlight to you the severe cases. What are the most important for us? That were prevalent in female gender, more than 50 years. Most of them were drug-induced and with a higher number of comorbidities. What I would like to highlight here is that most of these ladies had personal history of drug allergy. So they had drug-induced anaphylaxis, even have a personal history of drug allergy. And this is very important. And I come back to you with another paper paper that I published before, that was a systematic review in which we analyzed all the data around the world related to the fatal drug-induced anaphylaxis. And what was remarkable for us is that 57% of deaths had personal history of drug allergy. And worse than that, 24% of this population had personal history of drug allergy of the same category. So it means that we have to have a good history in terms of the patients who had allergies or anaphylaxis in order to prevent these cases. Of course, this is the outcomes of this study, but something that we have the data is it enough good? No, it's not good. Is the reason why we at the end of this article we propose some perspectives and some actions in order to reduce these trends. So we propose actions that are, for example, optimization of healthcare pathways and optimization of referrals of cases of anaphylaxis, notification, education, and training in order to identify quickly the cases of anaphylaxis. Prevention and control of comorbidities that are risk factors of anaphylaxis, the global availability of auto-injectors, not only at the hospital, but in public settings as well, and implementing the ICD-11 to have an accurate data in terms of epidemiology of anaphylaxis, not only hospitalization, but mortality as well. So I end with this presentation related to anaphylaxis in order to introduce you the new journal, that's the Journal of Allergy and Hypersensitive Diseases that has been launched in 2023. This is the official international journal of the French Allergy Society, together with Elsevier, open access. We can now offer the waivers to all accepted articles during the new 2 years of the journal. And I'm very proud to introduce you our beautiful editorial board. So, and Puya, thank you very much for this opportunity. Puya is one of our active editors, and we have, of course, the traditional documents to be submitted, but we have new ones such as the JADE pipeline, in which we accepted articles with new technologies, new tools, new drugs, and clinical trials, and the JADE database or roundtable, in which we discuss very polemic situations. The last one was related to how to manage fish allergy. So with this, my dear friends, I would like to invite you to follow us in the social media and submit your papers into our new journal. Thank you very much.
Thank you, Luciana, for the brilliant presentation. I think that in the era of biological drugs and the side effect should be monitored, and I think that this is a pillar for the new generation of researcher, which will have all this information to build the differences between each subspecialty and analyze if there's a correlation between diseases and allergens and drug sensitivity and so on. And yes, I do think that the journal will make some impact in the future. And for those interested in the active talk, you can go on a journal which has been presented by Luciana by now, and you can have the possibility to download it because it's an open access journal for now. and you can read the entire article in the link that we will provide at the end of the talk. So you can just download the article and read the whole document. One thing that I would like to stress the resident or any others, as Luciana said, the possibility of having an open access article. I think it's so interesting. If you want to have your article to be widely exposed or reachable, I think that is a good opportunity that you should consider for publication in the future. Did you mention also that the journal is the original journal for the French Allergy Society?
Yeah, in fact, it's the official journal of the French Allergy Society, but in fact, it's really international. As you know, we have a very international editorial board, so it means that, in other words, we are welcoming articles from different regions of the world, and they will be reviewed as well by different colleagues that are able to see them critically.
Great. So let's go to the questions from the audience. The first question is coming from Italy. Are certain allergens more likely to cause severe cases compared to others?
Well, it depends, I think, in the age trend, probably. For example, we know that foods are more common allergens in kids, but the population that are more risky to evolve to severe reactions and to deaths are adolescents. So it's something that we have to keep in mind. On the other hand, we have the drugs and insect venom that are more likely to evolve to severe reactions in the elderly population. So, and as I mentioned, as much as we have comorbidities, it increases the risk of death.
Another question from Poland. Are there novel tools or technologies for monitoring severity in real time?
Well, I have been reviewing these new technologies because we have something in mind as well. But I mean, in clinical practice, it's not really broad. They are located in specific regions of the world. And I'm not sure if they are efficient enough to avoid death. So, I mean, it's something that we should try to go deeper on this.
Another question from Greece. Besides drugs, are certain allergens more likely to cause severe cases compared to others?
Yes, insect venom are something that is really, really important and in general trigger severe reactions. For example, when we compare the patterns of manifestations, what we can see is for drugs in general, we have cutaneous manifestation and then evolve with some respiratory conditions. For food, we have mainly cutaneous together with gastrointestinal manifestations. And to the insect venom, it's something that is really, really important, and they go directed to the shock. So it's something that is really important is that if you are facing a case with in which you suspect that are related to the venom, you have to put the patient in the Trendelenburg situation in order to avoid the consequences of the shock. So this is mandatory to these situations. And thank you for this question.
Another question from Portugal. Are there specific biomarkers that can predict the severity of an anaphylactic reaction?
Well, biomarkers in anaphylaxis have been studied so far. We have endotypes of anaphylaxis that have been described related to drugs and specific some biomarkers, but they are not markers for severity. They are markers for anaphylaxis and for the diagnosis. So unfortunately, so far we do not have markers that can say, okay, so it's more severe than the others. But we do know that IgE-mediated anaphylaxis are more severe than those that are not non-IgE-mediated.
Another question from Malaysia. What are the recommended first-line treatment for severe anaphylaxis?
Well, for severe anaphylaxis and non-severe anaphylaxis, adrenaline, epinephrine, intramuscular epinephrine is mandatory. So it's something that we can probably discuss in another session. But what is coming up in the market now are the intranasal epinephrine. That can be an option probably, but still requires clinical trials.
Okay. Our last two questions. The first from the USA. How do management protocols vary in resource-limited settings?
Well, as you may know, although I'm now based in France, I'm from Brazil. And then I know both sides of the issue. And I think one of the key issues we have in non-developing countries, such as in Brazil and other 65% of the world regions, is that we still do not have auto-injectors. And the patients are dying outside of hospitals. So in these situations, what is recommended is to provide the epinephrine, pre-fill syringes of epinephrine if it's available. But in other cases, I mean, give the epinephrine itself and try to train as much as possible the patients in order to avoid these situations.
Last question from Canada. Are there promising therapeutic targets currently under investigation?
Sorry?
Are there promising therapeutic targets currently under investigation?
Yes, there are some clinical trials, as I mentioned, related to nasal epinephrine, but we have sublingual epinephrine as well. Some devices that do not have the syringe that are go through pressure, but all of them are under clinical trials. The only one that has been validated by the FDA and EMA recently is the intranasal, but it's still not in the market.
It's fascinating how much importance nowadays it's the delivering system throughout the nose. It seems that so promising, the whole nose and nasal pathway throughout which we can develop all these vaccines and other therapeutic agents. It's I think that is promising for the future. What do you think?
I agree, and I think it can be an option that avoid the syringe, right? And
Yeah.
I think most of the children will be very happy with
Exactly.
this alternative. And I think as well for in specific situations in which the auto-injectors are not well received, such as at schools or in airplanes, is something that can be an alternative as well, an easier alternative. Although I know that the prices are not so different from the auto-injectors, but I think it can be something.
Great. Thank you, Luciana, for the brilliant presentation. And once again, everyone, make sure you're checking out for the Journal of Allergy and Hypersensitivity Disease, because it's a mandatory for your future research. In case you're interested, you can watch it again throughout our YouTube channel. So it has been recorded. Last week, reminder, the last session for this semester will be on December 4th. Our colleague Atis Subsaltis from Australia will talk about improving postoperative outcomes following sinus surgery. Thank you, Luciana, for being with us, and have a nice day.
Thank you, Puya. Thank you, everybody.